Welcome to Crazy Nurse RN Hub, where learning becomes a tradition. Come, join me as we explore the multifaceted world of nursing. Hi there, students. Welcome to Crazy Nurse RN Hub, where learning becomes a tradition. My name is Criselmer Ducanes, nurse educator, teaching medical and surgical nursing. As continuation to our topic on gas exchange and respiratory function, we have the management of patients with chest and lower respiratory tract disorders. Conditions affecting the chest and lower respiratory tract range from acute problems to chronic disorders. Many of these disorders are serious and often life-threatening. Patients with lower respiratory tract disorders require care from nurses with astute assessment and clinical management skills, as well as knowledge of evidence-based practice. Nurses must also understand the impact of the particular disorder on the patient's quality of life and ability to carry out usual activities of daily living. Patient and family education is an important nursing intervention in the management of all lower respiratory tract disorders. I have here an image of the structures of the respiratory system as your reference. Now let's have atelectasis. It refers to closure or collapse of alveoli and often is described in relation to X-ray findings and/or clinical signs and symptoms. Commonly encountered abnormalities seen on chest X-ray. We also have acute atelectasis. It is most commonly described atelectasis. It occurs most often in the post-operative setting or in people who are immobilized and have a shallow, monotonous breathing pattern. Excess secretions or mucus plugs may also cause obstruction of airflow and result in atelectasis in an area of the lung. Now let's have the two types of atelectasis. First, we have the non-obstructive. It occurs in adults as a result of reduced ventilation. We also have obstructive. It occurs as a result of any blockage that obstructs passage of air to and from the alveoli, thus reducing alveolar ventilation. Obstructive atelectasis is the most common type and results from reabsorption of gas. No additional air can enter into the alveoli because of the blockage. Now let's have the etiologies. In addition, atelectasis may develop because of excessive pressure on the lung tissue, which restricts normal lung expansion on inspiration. Such pressures can be produced by fluid accumulating within the pleural space. It is called as your pleural effusion. We also have a term pleural space. This is the area between the parietal and the visceral pleurae. We also have the pneumothorax. It is the air in the pleural space. And also we have the hemothorax. It is the blood in the pleural space. So there is a great difference between the pneumothorax and hemothorax. So this is an example of your pleural effusion. So in this image, you can see that there is a fluid between the pleural space. So that is your pleural effusion. We also have your pneumothorax. Okay, so it is the presence of air in the pleural space. We also have the hemothorax. So there is a presence of blood in the pleural space. Also, there is a combination hemo and pneumothorax. There is a presence of air and blood on the pleural cavity. Now let's have the clinical manifestations. So this is a general manifestations of your atelectasis. First, there is an increasing dyspnea, cough. We also have sputum production. For the clinical manifestation of your acute atelectasis, it is marked with respiratory distress, tachycardia, tachypnea, pleural pain. We also have central cyanosis. It means there is a bluish skin hue that is a late sign of hypoxemia. Difficulty of breathing in supine. So these are the clinical manifestations under your acute atelectasis. Now let's have the clinical manifestations of your chronic atelectasis. It is similar to acute atelectasis. Signs and symptoms are similar to as what I have said, the acute atelectasis. The chronic nature of the alveolar collapse predisposes patients to infection, distal to obstruction. Therefore, the signs and symptoms of pulmonary infection also may be present. Assessment and diagnostic findings. There is a decreased breath sounds and crackles upon auscultation, patchy infiltrates or consolidated area on X-ray, low saturation of hemoglobin with oxygen, less than 90%. Now let's have the prevention. So this condition can be prevented by way of frequently turning the patient, early mobilization, and strategies to expand the lungs and to manage secretions. We also have voluntary deep breathing maneuvers at least every 2 hours. We also have to educate our patient and reinforce health teachings. And of course, we have to perform or implement secretion management techniques. Now let's proceed to the management. The goal is to improve ventilation and remove secretions. If it is caused by bronchial obstructions, secretions must be removed by coughing or suctioning to allow air to re-enter the portion of the lung. And if it is caused by compression of the lungs, the goal is to decrease the compression. And for chronic atelectasis, it focuses on removing the cause of obstruction of the airways or the compression of the lung tissue. Now let's proceed to the respiratory infections. So we have your acute tracheobronchitis, pneumonia, aspiration, severe acute respiratory syndrome or your SARS, pulmonary tuberculosis, lung abscess. For acute tracheobronchitis, an acute inflammation of the mucous membranes of the trachea and the bronchial tree often follows infection of the upper respiratory tract, caused by Streptococcus pneumoniae, Haemophilus influenzae, Mycoplasma pneumoniae, and Aspergillus. This is a fungal infection. For the clinical management, we have dry irritating cough, scanty amount of mucoid sputum, sternal soreness, fever or chills, night sweats, headache, and general malaise, inspiratory stridor, and expiratory wheeze. We also have purulent or pus-filled sputum. And for severe case, there is a blood-streak secretions. Now let's have the medical management. We have to administer antibiotics since this is an infection. Also, we have to encourage our patient to increase fluid intake. Also, we have to suction the patient so that the secretions will be removed. And also, we have to perform bronchoscopy. Okay, this is a way of removing secretions and also to check the status of the lungs. Endotracheal intubation to provide artificial airway, and we also manage this condition by symptomatic treatment such as cool vapor therapy or steam inhalation and moist heat to the chest. This relieves coughing and inflammation of the lungs. Now let's have the nursing management. Acute tracheobronchitis is usually treated at home. We have to encourage bronchial hygiene, such as we have to increase fluid intake, directed coughing, sit up frequently to cough. Also, we have to encourage and advise our patient to complete the course of antibiotics and advise to rest. Now let's proceed to pneumonia. It is an inflammation of the lung parenchyma caused by various microorganisms, including bacteria, mycobacteria, fungi, and viruses. We also have here a term called pneumonitis. Okay, it is a more general term that describes an inflammatory process in the lung tissue that may predispose or place the patient at risk for microbial invasion. We have here different classifications of pneumonia. We have your community-acquired pneumonia, healthcare-associated pneumonia, hospital-acquired pneumonia, and ventilator-associated pneumonia. For community-acquired pneumonia, or the CAP, pneumonia occurs either in the community setting or within the first 48 hours after hospitalization or institutionalization. The need for hospitalization for CAP depends on the severity of the pneumonia. We also have your healthcare-associated pneumonia, the HCAP. Pneumonia occurring in a non-hospitalized patient with extensive healthcare contact with one or more of the following. First, hospitalization for less than 2 days in an acute care facility within 90 days of infection. Residence in a nursing home or long-term care facility. Antibiotic therapy, chemotherapy, or wound care within 30 days of current infection. Hemodialysis treatment at a hospital or clinic, and family member with infection due to multi-drug resistant bacteria. We also have your hospital-acquired pneumonia, the HAP. It develops 48 hours or more after admission and does not appear to be incubating at the time of hospital admission. We also have your ventilator-associated pneumonia, the VAP. It is a type of hospital-acquired pneumonia that develops more than 48 hours after endotracheal tube intubation. Now let's have the pneumonia in the immunocompromised host. It includes pneumocystic pneumonia, PCP, fungal pneumonias, and Mycobacterium tuberculosis. The organism that causes PCP is your pneumocystic Hirovici. It occurs with the use of corticosteroids or other immunosuppressive agents, chemotherapy, nutritional depletion, the use of broad-spectrum antimicrobials, AIDS, genetic immune disorders, and long-term advanced life support technology. Now let's have the aspiration pneumonia. It refers to the pneumonia consequences resulting from entry of endogenous and exogenous substances into the lower airway. We have bacterial infection, which is the common form of aspiration pneumonia. It may occur in community or hospital setting. For the risk factors of your aspiration pneumonia, we have conditions that produce mucus or bronchial obstruction, immunocompromised patients such as with HIV or immune disorders, smoking, prolonged immobility and shallow breathing, depressed cough reflex, nothing per orem, NPO, or there is a presence of nasogastric tube and endotracheal tube, supine position, antibiotic therapy, alcohol intoxication, anesthesia, and old age. So these are the risk factors under your aspiration pneumonia. Now let's have the clinical manifestations. So there is a sudden onset of chills ranging from 38.5 degrees Celsius to 40.5 degrees Celsius. Pleuritic pain, marked tachypnea, between 25 to 45 breaths per minute. Respiratory distress, relative bradycardia, upper respiratory tract infection as well. Orthopnea, it is the shortness of breath when reclining or in the supine position. And also mucoid and purulent sputum. Now let's proceed to the assessment and diagnostic findings. First, we have to obtain complete health history and physical examination. X-ray, blood culture. Since the most common cause is bacterial infection, so we have to perform blood culture to identify the causative microorganism or agent. Sputum examination, bronchoscopy. So now let's discuss the procedures on how to obtain sputum sample. First, we have to rinse the mouth with water to minimize contamination by normal oral flora. Breathe deeply several times. Cough deeply. Expectorate the raised sputum into a sterile container. Now let's discuss about the prevention. Pneumococcal vaccination reduces the incidence of pneumonia, hospitalizations for cardiac conditions, and deaths in the general older adult population. So, as a preventive measure, we administer pneumococcal vaccines to our patient. Now let's have the medical management. So first, we have your pharmacologic therapy. So we administer antibiotics for bacterial infection. However, antibiotics are ineffective for viral infection. So it is very important to understand and to know which infection or which causative agent is producing the disease. Okay? Other therapeutic regimens we have supportive management. Hydration, we have to increase the oral fluid intake of our patient. Antipyretics for fever. We also have bed rest. Okay, we encourage our patient to have bed rest. Complications. We have shock and respiratory failure. So severe complications of pneumonia include hypotension and septic shock and respiratory failure. We also have pleural effusion as one of the complications of your pneumonia. There are 3 stages of parapneumonic pleural effusion. First is the uncomplicated empyema, complicated empyema, which is the second stage, and lastly, the third stage, we have your thoracic empyema. The empyema means it occurs when thick, purulent fluid accumulates within the pleural space, often with fibrin development and a loculated wall-off R where infection is located. So there is an accumulation of pus in the pleural space. That is your empyema. For the nursing management, we have to improve the airway potency. Removing secretions is important because retained secretions interfere with gas exchange and may slow recovery. We also have to promote rest and conserve energy. The nurse encourages the debilitated patient to rest and avoid overexertion and possible exacerbation of symptoms. The patient should assume a comfortable position to promote rest and breathing, such as semi-Fowler's position, and should change positions frequently to enhance secretion clearance and pulmonary ventilation and perfusion. We also have to promote fluid intake. The respiratory rate of patients with pneumonia increases because of the increased workload imposed by labored breathing and fever. An increased respiratory rate leads to the increase in insensible fluid loss during exhalation and lead to dehydration. Therefore, unless contraindicated, increased fluid intake, at least 2 liters per day, is encouraged. Next, we have to maintain nutrition. Many patients with shortness of breath and fatigue have a decreased appetite and consume only fluids. Fluids with electrolytes may help provide fluid, calories, and electrolytes. Small, frequent feeding or meals may be advisable. Other nutritionally enriched drinks or shakes may also be helpful. In addition, IV fluids and nutrients may also be administered if necessary. Next, we have to promote patient's knowledge. The patient and family are instructed about the cause of pneumonia, management of symptoms, signs and symptoms that should be reported to the primary provider or nurse, and the need for follow-up. The patient also needs information about factors, both patient risk factors and external factors, that may have contributed to the development of pneumonia, and strategies to promote recovery and prevent recurrence. We also have to monitor and manage potential complications, such as continuing symptoms after initiation of therapy, shock and respiratory failure, pleural effusion, and confusion. Next, we have to promote home and community-based care, such as educating patients about self-care and continuing care. Now let's have aspiration. It is the inhalation of foreign material, for example, oropharyngeal or stomach contents, into the lungs. It can occur when the protective airway reflexes are decreased or absent due to a variety of factors. A serious complication that can cause pneumonia and result in the following clinical pictures, such as tachycardia, dyspnea, central cyanosis, hypertension, hypotension, and death. Now let's proceed to the prevention. How do we prevent aspiration? First is by compensating for absence or absent reflexes. Aspiration may occur if the patient cannot adequately coordinate protective glottic, laryngeal, and cough reflexes. This hazard is increased if the patient has a distended abdomen, is in supine, has the upper extremity immobilized in any manner, receives local anesthetic agents to the oropharyngeal or laryngeal area for diagnostic procedures, and has been sedated or has had long-term intubation. We also have to assess feeding tube placement. Tube feedings must be given only when it is certain that the feeding tube is positioned correctly in the stomach. Many patients receive enteral feeding directly into the duodenum through a small bore flexible feeding tube or surgically implanted tube. We also have to identify delayed stomach emptying. A full stomach can cause aspiration because of increased intragastric or extragastric pressure. The following may delay emptying of the stomach: intestinal obstruction, increased gastric secretions in gastroesophageal reflux disease, increased gastric secretion during anxiety, stress, or pain, and abdominal distension due to paralytic ileus, ascites, peritonitis, the use of opioids or sedatives, severe illness, or vaginal delivery. Lastly, we have to manage the effects of prolonged intubation. Prolonged endotracheal intubation or tracheostomy can depress the laryngeal and glottic reflexes because of disuse. Patients with prolonged tracheostomies are encouraged to phonate and exercise the laryngeal muscles. For patients who have had long-term intubation or tracheostomies, it may be helpful to have a speech therapist experienced in swallowing disorders work with the patient to address swallowing problems. Now let's proceed to the severe acute respiratory syndrome, or SARS. It is a viral respiratory illness caused by a coronavirus called SARS-associated coronavirus. It is transmitted via respiratory droplets when an infected person coughs or sneezes. It can be transmitted via infected surface or object also. Now let's have the characteristic symptoms. Fever greater than 38 degrees Celsius. Coughing, difficulty of breathing, headache, overall feeling of discomforts, body aches, and diarrhea. So these are the characteristic symptoms of severe acute respiratory syndrome. Now let's discuss about the incubation period. It is usually 2 to 7 days, although longer periods have been reported. And it is associated, there is an associated risk factors with poor outcomes or prognosis. First, we have older age, comorbid conditions, atypical symptoms, elevated serum lactate dehydrogenase on admission, and acute renal failure. So once you have noted this to your patient, these associated risk factors, and he or she has a severe acute respiratory syndrome, so there will be a poor outcome or poor prognosis of his or her condition. Now let's discuss the management. There is no treatment except supportive care. Infection control measures. We have to limit the transmission, and this is the priority measure. The CDC guidelines here gives us the following protocols or following measures to observe. First is we have to have a negative pressure isolation rooms for infected patients. We would also encourage to wear personal protective equipment. Also, we need to practice hand hygiene, environmental cleaning and disinfection techniques, and source control measure. Now let's discuss pulmonary tuberculosis. It is an infectious disease that primarily affects the lung parenchyma. Can be transmitted to other parts of the body, including the meninges, kidneys, bones, and lymph nodes. Mycobacterium tuberculosis, it is the primary infectious agent, and it is an acid-fast aerobic rod that grows slowly and is sensitive to heat and ultraviolet light. Mycobacterium bovis and Mycobacterium avium, rarely associated with TB infection. For the transmission and risk factors, so it is transmitted through airborne. Droplet nuclei, usually particles 1 to 5 mcm in diameter, are released through talking, coughing, sneezing, laughing, or singing. Larger droplets settle, small droplets remain suspended in the air and are inhaled by a susceptible person. For the clinical manifestation, we have, so the signs and symptoms are insidious. We have low-grade fever, cough, it may be non-productive or mucopurulent sputum. Hemoptysis also may occur. Night sweats, fatigue, and weight loss. For the assessment and diagnostic findings, we have to obtain complete history and physical examination. Also, we have to perform tuberculin skin test, chest x-ray. There will be a lesion in the upper lobes as a result for tuberculosis, pulmonary tuberculosis. Drug susceptibility testing, and it is repeated at 3 months for patients who do not respond to therapy. Now let's discuss your tuberculin skin test. It is also known as your Manteau test. It is used to determine whether a person has been infected with the TB bacillus. Widely used screening test for latent Mycobacterium tuberculosis infection. And it is a standardized intracutaneous injection procedure and should be performed only by those trained in its administration and reading. And tubercle bacilli extract, the tuberculin, which is a purified protein derivative, is injected into the intradermal layer of the inner aspect of the forearm, approximately 4 inches below the elbow. So this is how your Manteau test or your tuberculin skin test is being done to the patient. So it would create an induration on the skin. There will be an induration, or some other books would call that as a wheal. We have here the interpretation of your skin test. So for patients who have an induration of more than or equal to 5 cc, who are HIV positive, with recent contact with an active TB patient, nodular or fibrotic changes on chest x-ray, and organ transplant. Okay, so the more than or equal to 5 mm induration is considered positive Manteau test for them. Okay. For patients who have recent arrivals of less than 5 years from high prevalence countries, IV drug users, resident or employee of high-risk congregate settings, mycobacteriology lab personnel, comorbid conditions, children less than 4 years old, and infants, children, and adolescents exposed to high-risk categories, an induration of more than or equal to 10 mm is considered a positive Manteau test. However, for persons with no known risk factors for TB, more than or equal to 15 mm induration is considered as positive Manteau test. So these are the following interpretation of your Manteau test based on the different types of patients with various conditions. We also have your QuantiFERON TB Gold test. It is an enzyme-linked immunosorbent assay, or your ELISA, that detects the release of interferon gamma by WBC when the blood of a patient with TB is incubated with peptides similar to those in Mycobacterium tuberculosis. So this is done by 4 ways. First, we have to collect the blood. Then we have to mix and incubation of tubes, mixing and incubation of tubes. After that, there is a manual or automated ELISA. Okay, so we'll be using here machines. Then after that, objective result calculation using a software will be obtained. We also have sputum culture. The presence of AFB or acid-fast bacillus on a sputum smear may indicate disease but does not confirm the diagnosis of TB because some AFB are not Mycobacterium tuberculosis. Hence, a culture is done to confirm the diagnosis. Medical management. So we have here the anti-tubercular or anti-TB agents administered for 6 to 12 months. A prolonged treatment duration is necessary to ensure eradication of the organism and to prevent relapse. The continuing and increasing resistance of Mycobacterium tuberculosis to TB medication is a worldwide concern and challenge in TB therapy. So we have here 4 commonly used anti-tubercular drugs. First, we have your rifampicin, and the most common side effects of this is orange urine and other body secretions. We also have your isoniazid. Common side effect for this is your peripheral neuritis. We also have your pyrazinamide, and the common side effects is your hyperuricemia. Lastly, we have your ethambutol, which is the common side effect for this is optic neuritis. Now let's have the types of drug resistance. First, we have your primary drug resistance. Then we have the secondary or acquired drug resistance. Third, we have your multi-drug resistance. Now let's discuss the primary drug resistance. Resistance to one of the first-line anti-TB agents in people who have not had previous treatment. We also have the secondary or acquired drug resistance. Resistance to one or more anti-TB drugs in patients undergoing therapy. We also have your multi-drug resistance. Resistance to 2 agents, isoniazid and rifampicin. The populations at greater risk for multi-drug resistance are those who are HIV positive and institutionalized or homeless. For the nursing management, we have to promote airway clearance. Also, we have to advocate adherence to the treatment regimen. Also, promote activity and adequate nutrition. Also, we have to prevent transmission. So these are the 4 major nursing management that we should observe or implement for patients who have pulmonary tuberculosis. Now let's proceed to the lung abscess. It is a necrosis of the pulmonary parenchyma caused by microbial infection and is caused by aspiration of anaerobic bacteria. And chest X-ray demonstrates a cavity of at least 2 centimeters. Now we have the clinical manifestations. It may vary from mild productive cough to acute illness. So we have here fever, productive cough, leukocytosis, pleurisy, dyspnea, weakness, anorexia, and weight loss. We also have the assessment and diagnostic findings. So first, we have here the physical examination. So you will observe or note that there is dullness on percussion, decreased or absent breath sounds with intermittent pleural friction rub, the grating and creaking sounds on auscultation. For the confirmation of the diagnosis, we have your chest X-ray, sputum culture, and fiber optic bronchoscopy. Chest X-ray reveals an infiltrate with an air fluid level. And CT scan of the chest, it provides detailed images of the different cross-sectional areas of the lungs. For the prevention, we have here appropriate antibiotic therapy, because any dental procedures in patients who must have teeth extracted while their gums and teeth are infected. We also have adequate dental and oral hygiene, because anaerobic bacteria play a role in the pathogenesis of lung abscess. Also, we have to appropriately administer antimicrobial therapy. Now let's proceed to the medical management. First is to adequately drain lung abscess. So by way of performing postural drainage and chest physiotherapy. We also have to insert, or there is an insertion of a percutaneous chest catheter for long-term drainage of the abscess or the pus in the lungs. We also have here therapeutic use of bronchoscopy. So in this instance, bronchoscopy is not used as a diagnostic tool. However, it is used as a therapeutic management. That means we perform bronchoscopy in order to drain or get the abscess or pus from the lungs. Diet high in protein and calories. So this would help in recovery or wound healing. IV antimicrobials, okay, for bacterial infectious causation. We also have your surgical management. We have here lobectomy. It is performed for massive hemoptysis. Now let's have the nursing management. First, we have to conduct health teachings on medication administration, chest physiotherapy, deep breathing and coughing exercises, and we have to encourage high protein and calories diet, and of course we have to support our patient emotionally and psychologically.